Today's webinar is being hosted by the Maternal Health Learning and Innovation Center. We are based at UNC in Chapel Hill and supported by our partners in multiple states. Shout out to Rose, based in Atlanta, for helping us curate this series. And now, without further ado, I would like to introduce today's speaker, Betsy Collins, a physician, OBGYN, at Emory University in Atlanta. She identifies as queer and has given me wide breadth to shorten her bio by letting you know that she does lots of breastfeeding work and much more that she's going to cover in today's presentation. So thank you all. If you just joined us, please feel free to introduce yourselves in the chat. I will be monitoring the chat for Q&A, so anytime you have questions, please feel free to enter them and we will answer them at the end. Betsy, over to you.
Thank you so much. I would also like to say that I really like bicycles. That's my other passion besides taking care of people. So if you wanted to summarize my bio, she's an OBGYN who does some breastfeeding medicine and likes bikes. There you go, right? I probably should have just told you that at the beginning.
Fantastic.
So our talk today is on supporting the lactation goals of LGBTQIA+ families. This may cover some basics that you're already very familiar with, and then also some pretty specific details about this journey for our patients, but bear with me. It should hopefully touch on lots of different levels of experience with this patient population. So if some of the beginning stuff seems a little basic, don't worry, we won't drag too slowly through that section. This presentation was originally made with 3 other presenters. It started with a talk that we gave to the Gay and Lesbian Medical Association, and then progressed to a talk that we gave at the U.S. Professional Association of Transgender Health. The other providers and community members that I've worked with are Dr. Aburn, who's now at Brown, Kay Greenberg, who is a lawyer and the staff attorney for the Center of HIV Law and Policy. He also identifies as transgender. A transgender man, is a birthing person and has chest fed. And then Alicia Simpson, who's an IBCLC and runs PPOD nutrition and lactation support. And I would just like to say thank you very much for the honorarium for this talk. All the other speakers authors of this presentation have donated their portion of today's proceedings to Alicia Simpson's business, PPOD Nutrition and Lactation Support, to help continue to provide care for LGBTQIA and other minoritized families. So thank you. I have nothing to disclose other than the honorarium for this talk. Thank you. Our objectives today are to identify human lactation as a very gendered experience, describe inclusive language that we can use when discussing human lactation, briefly discuss lactation induction, describe ways to support lactation in LGBTQIA+ patients, review donor milk safety and access, also discuss the Academy of Breastfeeding Medicine statement on language, and if we have time, a case study, but I would primarily like to get through the slides and get to questions if that is more helpful. So what does this letter salad LGBTQIA+ mean? It means a lot of things and it's constantly changing. So the best way I can describe it is to say that it's a huge hodgepodge and more things will be added, maybe even things will be taken away eventually, but just know that this giant group of humans has a very wide breadth of experience, and that the needs of a person who identifies as intersex may be very different than the needs of someone who identifies as a gay man. So take that all with a grain of salt. So it stands for lesbian, gay, transgender, bisexual, or pansexual, which means sexually attracted to all genders. Bigendered, meaning identifying as both male and female or neither male or female. Queer or questioning. Asexual, agender, intersex, non-gender binary, et cetera, et cetera. I'm just going to briefly go through some definitions so that we're all sort of on the same page, but again, this may sound basic. Someone identifies as cisgender when you identify with the gender and sex that you were assigned at birth. So, if you were assigned female sex at birth and you identify as a woman or a girl, you would be described as cisgender. A transgender person or people describes people who identify as the gender or sex other than that which they were assigned at birth. So let's say you were assigned female at birth but identify as male, you would be described as transgender. Non-binary describes somebody who identifies as both male and female, neither male nor female, or something else entirely. So it just means something that doesn't fit neatly into the discrete categories of male or female. Other definitions that you may see in this talk, we'll start with dead name, which if you're a transgender person or a non-binary person, if you were assigned a name at birth, but you no longer use that name because it does not conform with your gender identity, your name that you were assigned at birth would be your dead name. So let's say you were given the name Jennifer at birth and your assigned sex was female, but now you identify as male and you changed your name to James. Jennifer would be your dead name. AMAB or AFAB means to be assigned male at birth or assigned female at birth. Ally is a person who does not identify as gender or sexuality diverse, but is an advocate for the community. Polyamorous just means non-monogamous. It is not related to sexual preferences or orientation. So if someone says, I'm poly, it doesn't tell me who they have sex with. It just means they have more than one partner. So formerly used words would be things like promiscuous. So I had a patient who was in her 50s and I was asking her about her sexual activity and she said, well, I'm promiscuous. And I was like, what does that mean? We don't use that word anymore. And she said, well, I have a boyfriend, but I have a couple boyfriends. And so I was like, ma'am, we don't say that anymore. We're going to say polyamorous because it is a lot less judgmental. Fluid bonded is if you are polyamorous, you may have a primary partner that you don't use barrier sexual protection with. So if that patient had said to me, well, I've got 2 boyfriends, but I'm also married to my husband and I'm fluid bonded with my husband, it means that she doesn't use condoms with her husband, but she uses condoms and other barrier protection when she engages in sexual activity with her boyfriends. Does that make sense? Asexual means you are not interested in sexual activity with another person or partner, regardless of your relationship status. There are asexual people who are in long-term relationships that they would consider romantic relationships. They are just not sexually active with that person or not interested in sexual activity with that person. It is not the same as abstinence. People who are abstinent desire sexual activity with other people, but are not currently active or choose not to be currently active. Other definitions, you may see genderqueer, which refers to individuals who blur preconceived boundaries of gender in relation to the gender binary. That's pretty similar to gender nonconforming, which is a term for those who do not follow gender stereotypes. I personally identify as genderqueer or gender nonconforming. We already talked about AMAB and AFAB. I really like this graphic. It's called The Genderbread Person. It's available online. And this is a slightly older version of it, but I like it because it's pretty easy to discuss in a talk. And the 3 things that I think are most important on this graphic are going to be gender identity, gender expression, and biological sex. Sexual orientation, I think, is the least helpful thing, and I'll explain why in a second. But I want everyone, as I go through this description of these categories, to think about yourself and where you fit in these categories. I'm going to describe myself in relation to these categories. So first thing we're going to start with is gender identity. Gender identity is how you in your head think about yourself. It's the chemistry that composes you, including hormone levels, and how you interpret what that means. So for me, as I just stated, I identify as genderqueer, which is sort of somewhere in the middle between identifying as a woman or a man. Gender expression is how you demonstrate your gender based on traditional gender roles and stereotypes through the ways that you act, dress, behave, and interact. So gender expression can change over time, not necessarily just in a person, but sort of historically, right? There may be things, for example, that we do now that were traditionally stereotypically associated with being a different gender or being associated with a different gender. I'll give pink as an example. About 120 years ago, pink was considered a very masculine color. Um, Boys often wore pink. Again, it was a stereotypical choice. Now we stereotypically associate pink with femininity or being a girl. So again, your gender expression is in relationship with whatever the stereotypical gender norms are of that time. I would consider myself personally androgynous, maybe lean masculine in terms of my gender expression. And the other thing I want to say is that your gender expression and your gender identity don't have to match. So, as I like to say, they don't have to be matchy. And the reason why I bring that up is because it is incredibly important to know that you cannot look at someone and know their gender identity. Just in the same way, I can't look at someone and know what name they like to be called or know what kind of sexual partners they have. You have to ask. And so that's what makes this so important, is that we are moving away from understanding that there's only one stereotypical way for people to be, stereotypically feminine or stereotypically masculine, and understanding that there's a spectrum of expression in the middle, and that that's perfectly okay, but that we can't look at someone and know. Like you could have a very big beard and a very masculine appearance and identify as a woman. So just know that that adds a level of complexity, especially for those of us that grew up in a very sort of stereotypically gendered place, like America, for example, or like many places on this planet. But that it's something that we need to sort of open our minds to in terms of understanding that gender expression, meaning how we demonstrate our gender, comes in lots of different flavors. Biological sex refers to the objectively measurable organs, hormones, and chromosomes that a person has. So someone who is assigned female will likely have a vagina, ovaries, and XX chromosomes. Someone who's assigned male biologic sex has a penis, testes, and XY chromosomes. And someone who's intersex has a combination of the two. So people don't identify as intersex. People are intersex or they're not. Now, there are flavors of intersex because our biological sex actually has a lot of components. As you can see, there's the genitals, there's the gonads, there's the chromosomes, and how our body responds to those things. But because someone identifies as gender queer or gender non-binary does not make them intersex. You have to have measurable aspects that combine both female and male organs, hormones, or chromosomes. So gender identity and biological sex are very different, just so that everyone's clear about that. And intersex people have oftentimes been sort of forgotten in this conversation. But when you hear someone say, oh, people are either born a girl or a boy, number one, that's not true. And number two, again, we're talking about sex, and sex comes in more than two flavors. So just again, want to admit that intersex people are real, and that we need to continue to tell people that this idea that people are either born male or female only is not true. Lastly, we have sexual orientation, which is my least emphasized portion of this, because sexual orientation is who you are physically, spiritually, and emotionally attracted to based on their sex or gender in relation to your own. So that's hard because it includes another person or people, and those people may not be sitting in front of you. And so, if I have a patient who says, well, I identify as a gay man, that's fine. But if they're a transgender gay man and they have a vagina and their romantic partner has a penis and is a cisgender man, that's very different than two cisgender men who were assigned male at birth and who are partnered, because suddenly I have a risk of pregnancy. Someone has a vagina and someone has a penis. that's very different than two cisgender men who are in a couple together. So you can see now that sexual orientation is a little bit less important to me because it doesn't tell me what I need to know about my patients. It is and can be important in a broader societal context, like things like if you're targeting a public health campaign at a specific group of people who may identify as a specific sexual orientation, that might be helpful. But on an individual basis, I don't find it particularly helpful. So why do we need to get better at this? The short answer is a lot of people identify as LGBTQIA+, and those numbers are only going up as younger people are more open and more understanding of the human experience in all of its variety. Currently, about 5% of the US population identifies as LGBTQIA, and 1% identify as transgender. In younger people, the number of people who identify as transgender is higher. So just keep that in mind. There's a lot of lack of familiarity with the needs of this population. While obviously we are seeing this change, there previously had been little formal education in professional school or workplace training around this subject. We talked a little bit about this already, but there is increased acceptability of non-heterosexual relationships and increased visibility of transgender people. There are some special risks associated with this patient population. People are worried about confidentiality. Unfortunately, violence and discrimination are still rampant towards LGBTQIA people, especially transgender people. And our patients are very, very, very worried about safety, and they should be. Currently in the United States, Black transgender women have a life expectancy of 37 years. And so I want everyone to sort of let that sink in and understand that oftentimes I have patients that could be described with a single sentence in Google and you could get their photo and their identity. So we need to be very cautious about safety, about HIPAA, about social media, and making sure our patients have a safe experience when they interact with us. We also want to provide the right care to the right patient at the right time. And we want our patients to come back to us because many patients are driven away from our healthcare settings because they've had a bad experience. Language in the reproductive space is very gendered. I currently and through my entire career worked in a women's health clinic. I have obviously a lot of experience in breastfeeding medicine. I am a mom. I'm a parent. I've been a non-gestational parent. Our postpartum unit is called the mother-baby unit. It's a very difficult space to navigate when you don't neatly fit into the box of male or female. And so we are really trying to encourage people to use gender neutral language or gender inclusive language. So I remember one day we were having grand rounds and my chair said, what does everyone think about the controversy and this idea of saying pregnant people instead of pregnant women? And I said, well, why don't we say pregnant women and pregnant people? Because then if someone strongly identifies as a woman and likes to be seen in that way, we've included everybody. And so I tend to be a person who adds more words because I feel then it allows patients to see themselves in our care and our language. I love terms like birth parent, birther, or gestational parent. So feel free to practice, but the point is sometimes you have to be a little bit of a gymnast with your words to try to make sure that you're including people. Patients may use different words to describe their body parts. I try to mirror whatever language patients use for themselves. So if a patient said, hey, I've got a lump in my chest, use the word chest. Someone says boob, I use the word boob. So, I really try hard to sort of meet the patient where they're at and use the terms they would use. This is just a sample from the Callan Lord Clinic, which is one of the largest transgender health clinics in the country. It's in New York City. But I wanted to give people some examples of less gendered terms for some of the kind of classically gendered reproductive health terms that we use. So you can see things like, instead of using vulva, using external genitals, instead of penis or testicles. You could say outer parts. So this is just some examples, but wanted to show you that it absolutely can be done. This is an inclusive graphic that has sort of really nice inclusive imagery about different types of people who might be breast or chest feeding, uses inclusive language. So these are the kinds of things to keep an eye out for as you're making information for your patients. All right, so let's move into talking specifically about transmasculine people. So obviously in accessing a sort of very gendered space like reproduction, a lot of transmasculine people feel lots of different feelings as they are pregnant and considering how they're going to feed their babies. There's really only one major study looking at dysphoria around being a transmasculine breast or chest feeder. The study had 22 participants. They described, the feeling of having their chest grow as they were starting to produce milk, how that affected how people perceived them, and then how they felt about their own bodies in relation to those changes. Having your chest tissue be more prominent is definitely can be a trigger for people who don't identify as female. And it can be something that sort of certainly I think many transmasculine or non-binary people feel is like very much a tell, and to suddenly have larger breast or chest tissue may feel very revealing to others. People have a hard time confining their chest. So binding, which is where you take like a large ace bandage or other sort of like tight elastic and bind the breasts or chest close to the chest wall, is very painful when you are trying to breast or chest feed. And not being able to do that and feeling like your chest is more prominent can contribute to gender or to chest related gender dysphoria. I would say I very much had that experience. I personally am not a very large chested person. When I was breastfeeding my baby, like it was a big change for me to suddenly have very prominent breasts and very heavy breasts. And I can't say that I loved it. While, I very much wanted to feed my baby human milk, it was something I sort of had to like not think about too closely because it wasn't really the way I like to see my own body. But I'm sure I'm not the only person who feels that way. And I'm sure there's also cis patients that don't like to see such a dramatic change in their body. And pregnancy is just one of those changes that we experience, large body changes, but the changes in our chests are certainly pretty dramatic. 7 of the 16 participants reported they experienced gender dysphoria. 5 individuals found ways to cope with the gender dysphoria, including using layered clothing or thinking about the utility of chest feeding. 2 participants had intense and overwhelming dysphoria, which was a main reason they could not continue chest feeding. And gender dysphoria did not always have to do with the individual's body, but how their body was being seen and gendered by others. So, if you're used to moving through space in sort of a very specific way in relation to your gender identity, and then suddenly you're being perceived very differently, that can be really hard. And so, think about a patient who, for example, maybe used to having like really amazing long luscious hair and then has to undergo chemotherapy and has to go through the world as a person without that long luscious hair, and how they're perceived and how their self-worth may be related to their appearance or their gender identity. These big changes in our bodies, especially related to our reproductive organs and our chest, can have a huge impact on how we feel we are seen by others. We talked a little bit about binding the chest, but these are some other things that can cause lactation issues. When to restart testosterone if you're going back on testosterone therapy after having a baby. We don't have a lot of good data on this. I believe there's one study showing minimal impact of testosterone therapy at 2 months after having a baby on lactation. But I wouldn't say that basing anything on one study is particularly robust. So definitely room for more work in that regard. Um, what clothing we wear. Most lactation clothing is aimed towards cisgender women. And I wouldn't say that, masculine clothing is really designed for that purpose. So, you're wearing a suit and a button down shirt or a tie. It's not the same as wearing a spandex shirt that easily lifts up where you can pump or breastfeed or chest feed while you're wearing that clothing. Binding is also something, if you've got a big ace bandage wrapped around your chest or a tight fitting bra, it may be very difficult to breast or chest feed or pump while you're wearing professional clothing or the clothing you would want to wear out of the house. So all those things can be an impediment. If breast or chest feeding is not that congruent with your gender identity, you may want a lot of privacy while you breast or chest feed. And that may be hard to accomplish. I know my office is a sliding glass door that's totally see-through. And while I'm very comfortable with my body, I know I have a lot of colleagues that are not necessarily that way. And I can only imagine if you did not feel good about your body or didn't feel that your body wasn't conforming with the way you thought your body should look, that, privacy would be a major concern when you were pumping or breast or chest feeding. All of these things can affect supply. So if you're less able to frequently breast or chest feed or have negative thoughts about breast or chest feeding, that certainly can impact supply. And then lots of people have had breast or chest surgery, including transmasculine individuals. So breast reduction, mastectomy, all of these things can affect supply. And in some indications, like with mastectomy, breast or chest feeding, using your own milk would be impossible. It's just some examples of some products out there: mother's milk tea, lactation cookies called Happy Mama, Oat Mama supplements, mother's hand tea, Earth Mama nipple butter. It's very, pink and in your face most of the time. We talked a little bit about surgery. So if you had a patient that was interested in restarting testosterone therapy after pregnancy and was lactating, probably the closest thing I can compare this to is patients that want to restart estrogen therapy after having a baby, either because their ovaries don't work or they want to use an estrogen-containing contraceptive. Estrogen has a pretty negative impact on milk supply. And while we don't have a lot of studies on this, I have a pretty strong suspicion, and we do have a little bit of evidence that testosterone interferes with prolactin production. So I would be very cautious about restarting testosterone and have a risk-benefit discussion with your patient. You could also use supplements, including an at-the-chest supplementer, to have a nursing relationship. So, occasionally I'll have patients that know that they're not going to be able to provide human milk that comes from their own chest, but they want to use an at-the-chest supplementer to have the latching experience. I wouldn't say it's very easy to set up, but if your patient wants to do it once or twice or even a few times, you can show them how to set it up, and it would give them the opportunity to try, even though they wouldn't necessarily be using their own milk. So lots of people have had breast and chest surgery, not just trans people, and any breast surgery can impact milk supply. So things to consider are whether or not the nipple has been detached. If it has been detached, getting milk from the breast or chest would be very difficult. How much mammary tissue has been removed. Most mastectomies for gender affirming purposes leave very little breast or chest tissue behind. Usually I tell patients it would be very unlikely for them to have any success because the nipple has been detached. You can talk to your patients about delaying surgery to accommodate breast or chest feeding. Just know that patients may find the experience very dysphoric while they've put off their chest surgery. But again, you have to balance the patient's goals and the risk-benefit relationship of using their own milk. A lot of patients have had periareolar incisions to do breast biopsies or have breast implants placed. and that can also impact the ducts that are leading into the nipple. Um, Depending on where a patient's implants might be, can also compress the mammary glands. So having implants underneath the muscle is better, but just know that the implant itself is going to act as a compress on the mammary tissue, which can decrease supply and cause engorgement. I always talk to my patients about how surgery might affect their experience, and consider an early lactation consult for anyone that's interested in using human milk that may have had a breast or chest surgery. And then obviously we want to watch our infants closely for weight loss in these situations. We talked about all of this already. So sort of in summary, if you have a transmasculine individual who has had a mastectomy, I always let them know they won't be able to directly chest feed, but that we could use a nursing supplementer if they would like to try it at their own chest. We could use donor human milk if they prefer to use human milk exclusively with their babies. We can talk about lactation induction for a partner if they have a partner with intact mammary tissue, or the use of formula. So we've got some options, but the key is to have them and be able to discuss them easily. So specifically, the reason why binding is so destructive to the lactation process is that actually placing a lot of pressure on the breast or chest tissue directly inhibits lactation. So when we have patients that, for example, want to stop lactating, we actually tell them to wear a tight binder or a tight sports bra because of its ability to affect the glandular tissue. The other thing that's important is that years of binding the breast or chest prior to pregnancy and prior to lactation can adversely affect the glandular tissue. So while a patient may not bind directly during their lactation, the previous years of binding may have affected their ability to produce milk. And I always try to encourage patients that are planning on directly breast or chest feeding who like to bind, try to encourage them to stay away from it. During lactation, maybe only use it occasionally if their milk supply is well established. And I wouldn't do it for prolonged periods of time. And the other issue is that when you have a binder on, it's very difficult to remove your binder, especially for short periods of time. And I don't know, there are probably people on this call who have breast or chest fed or pumped, but it's really frequent. And having a binder on that you consistently have to take off and put back on and take off and put back on will be an impediment to frequently emptying the milk ducts, which will then cause lower supply. And the obstructed milk ducts that can occur from binding can lead to mastitis. And this is a little badge that we found online, but super cute. So every now and then I have patients who come in and they say, my wife is having a baby and I would really like to induce lactation so that we can both breastfeed our baby or test feed our baby. Obviously, nursing creates a hormonal bond between an infant and their nursing parent. We have patients that unfortunately are sometimes separated from their gestational parent or birth parent, or their birth parent may not be able to lactate safely, or they may need to be in the hospital for a prolonged period of time and can't be with their baby. So a lot of times parents want to induce lactation because it's a method of supporting their family, because they feel like they're trying to help the person who's accepting this entire burden on their own. It also provides a really special connection between a parent and a baby, and people perceive this as a means of sharing the caregiver role. Oh, I'll do this so my partner can rest, or get a few more hours of sleep. So it's really important to understand what the motivation is behind somebody who wants to induce lactation or be a non-gestational provider of human milk. And then some of the things that may be challenging about that. So the first thing we want to do is talk about expectations. So the person who is inducing lactation who is not pregnant needs to prepare for breast or chest feeding pretty much as soon as they know that they're going to be a parent. Because this is kind of a prolonged process, it's not something that you can sort of turn on a dime. Like I've had, for example, I had a woman who was about to be a grandmother call and say that she was interested in inducing lactation because her daughter was having a baby and she wanted to help out, and she had been really good at making breast milk. Now, there were some medical reasons why that was challenging, but the other problem is that she called a month before her grandchild was to be born. So we didn't, even if it had been safe, there was not enough leeway to get her ready for that experience. The other thing that's really important is that the amount of milk produced when inducing lactation can vary greatly. So one thing we like to say is that you absolutely can breast or chest feed, and it doesn't necessarily matter the quantity. You know, you making a tablespoon or 2 ounces of milk, even though you can't provide necessarily all of the milk that that child will need, may be fantastic and great for your baby, and that may continue to have that relationship and bond between you and the baby that you desired. So the quantity is not always necessarily important. And then the other thing, you know, we always remind our patients that we do have the nursing supplementer, which is a tube that runs down the chest and ends at the nipple and allows the baby to latch on and get nutrition through the supplemental tube without necessarily having that patient induce lactation. They could experience what it feels like to breast or chest feed. So we do have some options for people that maybe didn't come to us in time but want to have that experience a few times. So we talked a little bit about attachment, nutrition, healing, and sharing. I don't think I need to go over this slide again, but I would say the vast majority of patients I've had that have come to me with this request, it's because they really want to support someone that they love and sort of take the burden off of them. The composition of the milk that you make when you induce lactation is essentially the same as that which you would make if you birthed yourself. The milk itself does not contain dangerous levels of hormones. And it is also important to recognize it is not necessary to have an ovaries or a uterus to breastfeed, because prolactin is released from the pituitary gland. So if you have a patient that does not have ovaries or a uterus, you know, they're transgender, they've had a major reproductive surgery, they didn't develop a uterus, they're in menopause, those having functional uterus and ovaries is not required in any way. The process is separate from that. So induced lactation is stimulating milk production in a non-birthing parent. You do have to have mammary tissue. If you've already had a mastectomy, this will not work. We see this with non-birth parents, like we discussed earlier. Adoptive parents sometimes are very interested in inducing lactation, and other people who have not been pregnant but want to provide human milk to a baby. The concept is to mimic the physiologic preparation of the mammary gland during pregnancy, and then the changes that occur after delivery. That's why it takes months to induce lactation, because the mammary tissue during pregnancy is preparing for 10 months prior to delivery. And so we have to simulate that similar experience in the non-gestational person that we are trying to start lactation in. So it does take a long time. The most common method is something called the Newman-Goldfarb protocol. This is widely available online. Do know that if you look at the websites that discuss the Newman-Goldfarb protocol, they are very gendered. So, it'll say the mother, the woman. So just keep that in mind, especially if you're going to give it to a patient for a patient resource. Essentially, you would start Sprintec, which is a combined oral contraceptive containing estrogen and progesterone, plus domperidone 4 times a day, so 20 milligram, and I believe it comes in 10 milligram tablets, 4 times a day for 6 to 8 months. 6 weeks prior to the anticipated delivery, you're going to stop the oral contraceptives, continue the domperidone, and start to pump for 10 to 15 minutes every 3 hours or more frequently. Once your milk supply is established, you may be able to wean off the domperidone, although I'll say that probably most people do continue it. And the domperidone is available through Canadian pharmacies. Its use in lactation is considered off-label. It is not available in the United States, but I will say that getting it from reputable Canadian pharmacies is considered safe. Co-lactation is when both of the baby's parents are breast or chest feeding. So, the lesbian couple where one person is a gestational parent and the other person is a non-gestational parent, that would be, if both of those people lactated, that would be called co-lactation. So I am always open to the discussion and understanding the interests and goals and details of lactation induction and why the couple might be considering co-lactation. But I think one of the most important points that I always make, as I stated earlier, I have a lot of patients that say, well, I really want to help my wife by taking some of the burden away from her so that she doesn't always have to be the one to breast or chest feed. The problem with that idea is that the primary parent who carried the pregnancy, the gestational parent, if they want to maintain their milk supply, they can't skip a feeding to allow the non-gestational parent to provide human milk. They would have to wake up and pump to remove the breast milk or chest milk while the other person was breast or chest feeding the baby. So you can't skip a feeding as the gestational parent because that will affect your supply. So you still have to get up and do work, and then your partner is also doing work and getting up and breast or chest feeding the baby. And I think a lot of people don't realize that. They have this really great idea. They're like, I'm going to help. The other person can rest. When the reality of it is then you're both awake and you're both either pumping or directly breast or chest feeding the baby, and nobody really gets a break because you have to do it frequently to maintain your supply. If you skip feedings, your milk supply will go down because your mammary tissue will get the message that you don't want the milk. And so while it's well-intentioned, I would say a lot of people don't realize that. If people do plan on co-lactating, make a plan. I usually work with a lactation consultant who is experienced with this. You want to discuss the roles and responsibilities for support of the birth parents, childcare, and housework, and then discuss the lactation support for both parents and what that actually will look like. Oh, you will not be sleeping while I'm breast or chest feeding the baby. We'll both have to get up. We'll both have to remove milk from our mammary glands in order to keep our supply up. The other thing that I try to do if I have somebody who's interested in lactation induction, like the grandmother I mentioned earlier, I sort of redirected her. She wasn't safe to induce lactation based on her age and how many hormones are needed to induce lactation. So I talked with her a little bit about some ideas about how she could support her daughter and grandchild. And I really tried to redirect people's energy and remind them that, you're offering to help someone else. This isn't about you, and maybe you need to check in with your family member about what they need from you instead of sort of presuming that this very complex, time-consuming thing that you're about to go down the path of is what they would need. So again, making that plan and understanding what that person wants to do to help and whether or not the person being helped wanted that thing, I think is kind of an important thing to discuss. So now we'll move on to lactation induction in trans feminine people. So they're people assigned male at birth who are transgender and identify as women now. So we have two good case reports. One's called the Reisman paper, and then the other one is called the Wamble paper. I'll say that the Reisman paper, which is a case report of induced lactation in a transgender woman, is probably the most cited. Typically, we would use essentially the Newman-Goldfarb protocol, except these patients are already often on estrogen and progesterone. So you wouldn't necessarily have to start them on those medications. You just may have to change the dosing to be in concordance with the Newman-Goldfarb protocol. The one thing you do have to be careful about in any patient that's interested in lactation induction is contraindications. So if a patient has a high risk for blood clots or venous thromboembolus, if they're a smoker, they've had a stroke, they have vascular disease, lupus, cancer, you have to be very careful because high dose estrogen is thrombogenic and can cause blood clots. So the first thing I always do is take a good history and make sure a patient is eligible to be on estrogen and progesterone therapy. Serial lab work. If you're transgender, you're already getting some labs, but this protocol is pretty standardized. You don't need to check labs to check estrogen levels or progesterone levels. It's really about maintaining yourself on the medications, following the protocol, and pumping. So we'll go through exactly what that looked like for this patient in the Reisman paper. Patients that are transgender are often also on spironolactone, which is an anti-androgen, so it's used to suppress testosterone. It is not considered unsafe during breast or chest feeding, so there is no specific need to stop this medication. Domperidone, we talked about a little bit already. We do consider it safe, is safe during breastfeeding as well. And it's a selective peripheral agonist of dopamine 2 and 3 receptors. The biggest concern with the domperidone is that it can affect your heart rate. It does not cross the blood-brain barrier, and it can cause QT prolongation. So you have to be careful in patients that are already using things like fluoroquinolones, SSRIs, triptans, and antipsychotics. If they have a known issue with QT prolongation, you may want to get a baseline EKG, and again, have a risk-benefit discussion about safety. And again, you do have to get domperidone from a Canadian pharmacy, and it's legal to import it. Another nice graphic showing some inclusive images. So just to go back to I thought I had a slide on the Reisman paper. I'm going to go back here just for a second to discuss trans feminine induction. So patients are oftentimes already on estrogen and progesterone when they identify as trans feminine. In the Reisman paper, it talks specifically about the amount that the patient in the case study used. So you would continue them on daily estrogen and progesterone. You would initiate pumping every 2 to 3 hours, typically about 6 to 8 weeks prior to the anticipated delivery of the baby. And then 4 to 6 weeks before delivery, you would reduce the amount of estrogen that the patient is on to a low dose estrogen patch. So your patient does need to know that their estrogen levels are going to fluctuate during this time. That's another kind of key component that the patients need to understand. You won't be able to take that same higher dose level of estrogen. And then once milk supply is established, you would continue the domperidone and the estrogen and progesterone therapy and at those low dose levels. And then once the person was no longer lactating, you could increase their estrogen again. But the Reisman paper pretty clearly talks about the protocol that they used, and I would recommend using that. I really like to talk about milk sharing. I think it's something that is really sort of the next place that lactation support is going. Human milk banks in the United States are not widely available. They're becoming more available. But at human milk banks, milk is tested and sterilized and packaged for use typically by hospitals. The milk no longer has the active antibodies and microbes that fresh milk has. And it's also very expensive. It's about $5 an ounce. There is milk sharing available in the community, which is considered pretty safe. And then there's less formal networks for milk sharing through, for example, social media or on the internet, which we do not encourage. Never ever encourage someone to buy milk on the internet. Milk should be shared. So if anyone says, well, oh, someone offered to sell me their breast milk, strongly discouraged because it's usually contaminated and it's usually not human milk. We have strong history of, as human beings, of wet nursing between friends and family, between tribe members, communities. This is as old as time. So milk sharing is obviously safe and it's probably allowed for the continuation of humanity. If you have a patient that's interested in sharing their milk, you may be asked to sign a simple form confirming that the patient is healthy and doesn't have HIV and has had routine prenatal care. These are very basic forms. Please sign them. Milk is often available from a person who is a super producer and has lots of frozen milk available, or their baby can't drink it because of a metabolic problem, or they've had the loss of a child or a neonatal loss. Again, don't buy it online. Have a completed health screening form. And the other most important thing is that the milk be stored safely. The Academy of Breastfeeding Medicine has strict guidelines, as does the CDC. This is a sample of what those look like, but you should ensure the milk has been stored safely. Some additional considerations. People should meet either over the phone or in person to discuss milk sharing. Person should be in good health and not be on any medications that could be unsafe. They shouldn't use illicit drugs. And ideally, they would not be a heavy drinker or smoker. You can use home pasteurization. There are instructions for how to do that. But again, you're going to be killing off those antibodies that are in the milk that make it so healthful. It's probably not necessary, but some people choose to do that if they are being overly careful. And I think one of the most important take-home points is if you're in a community that has fewer people being pregnant or having babies, you may have fewer peers that have human milk for sharing. So they may have less access to the peer-to-peer milk sharing community. Human milk is always the healthiest thing for human babies. It optimizes nutrition, it's easily digestible, and provides immunologic protection. This does have some small risks, including the transmission of certain infectious agents like HIV. Some medications do cross into the breast milk, so that can be concerning, breast or human milk. And then environmental contaminants as a result of unhygienic storage or handling is probably the largest risk, which is why it's very important to make sure the milk has been stored correctly. We talked earlier a little bit about a nursing supplementer. This is just what it looks like. There's a reservoir, has small tubes that hang down across the nipple and would go into the baby's mouth, and it allows you to simulate milk production. And then one of my favorite things is skin to skin, which any person can do. It keeps parents and their babies together, promotes bonding. It provides for earlier initiation of breast or chest feeding, soothes the baby and the parent. And it allows babies to latch and nurse more efficiently when they are at the breast or chest. It can also help maintain body temperature and stabilize blood sugar, regulate the baby's breathing and heart rate, decrease pain from procedures, reduce postpartum hemorrhage, reduce stress, and increase the probability as well as length and time of breast or chest feeding. And the most important thing is that you should do it regardless of whether or not someone intends to breast or chest feed. It's just good in general. And that's it. Do we have any questions? I'll stop there just because we're getting to the point where this is getting close to the end.
Betsy, that was absolutely incredible. I wish we had 2 hours now because I feel like you could keep talking for a long time with even more information.
There's so much talking.
But it's great talking, such great talking. For anyone listening in, we are recording this. You will get a copy of the recording because I know that was a lot of information.
It's a
We are
lot.
not going to quiz you on it, but great stuff. So, some of the questions we got included, what does inducing lactation look like when the gestational parent has lactated for a previous pregnancy less than 5 years ago?
I'm assuming you mean not the non-gestational parent has lactated previously. It can be easier if you've lactated before. And so, just like anything else in obstetrics, usually what I tell people is if you've done it before, it's probably going to come back a little faster. And that'll probably give you a pretty good idea of supply. So I would say overall, if the person had a successful breast or chest feeding experience previously, their chance of successful induction is high. They still have to go through the same process, but their supply will likely come in faster and be better established than someone who's never done it before.
Next question, this came earlier in your talk. So lactating parents should use a sports bra to prevent binding?
So yes. So what I would recommend if someone says, hey, I really prefer binding as part of my, controlling my chest and my gender identity, I would say try not to, because we talked about how that would affect the mammary glands, and see if you can find a comfortable sports bra that would be sort of a middle ground. Again, if you're really binding the breast closely to the chest, wearing like a tight sports bra, even that will impact your supply. So, it's sort of a half step, is what I would say. The other thing that's nice about a sports bra is it's pretty accessible in terms of getting the breast or chest out for pumping or feeding. Whereas a binder, it's a big wrap around, and it's pretty hard to take it off and on. So I would encourage that as sort of a half step.
One last question. You'll see that I am not a clinician as I try and figure out what we're getting at here. It was a response. So there was a question about whether or not there's any issue with breastfeeding if you have HPV, whether HPV would interact with medications that would be used to induce lactation, and then a follow-up comment that may or may not have been related. This is my ignorance here. Was Reglan trade-offs, potential for increased depression, cross blood-brain barrier compared to availability, milk production levels, which persons respond. So there's a hodgepodge of words that may or may not all go together for you to interpret.
Okay, so let me answer the Reglan one and then just remind me of the first question again in a second. So I don't use Reglan at all in my practice anymore. I don't think it's helpful, and I think the side effects, like you said, mood, tardive dyskinesia, depression, its actual utility as a lactation galactagogue, I think is poor. So I don't use it anymore. So number one, Reglan, don't recommend. Although you're right, it is available at US pharmacies. I don't use it anymore. And then what was the first question?
Before I remind you of that first question,
Oh, HPV.
some folks might have to hop off right now. I just want to say, folks, keep an eye on your inbox. We are going to try to get an evaluation out to you because anyone that works in this sort of world knows how we need to collect evaluation data. And yes, the next question was HPV.
Okay, so breast and chest feeding is not affected by HPV infection. So there is no reason to not breast or chest feed because the person has a history of HPV. We all have HPV. It's incredibly common on the skin, in the genital area, and just in general on our bodies. So it does not affect our recommendations on lactation in any way.
And finally, because you haven't had time to look at the chat, you're getting lots of love. People found this very interesting, very helpful. So thank you so much for spending your time with us, both you and our audience. There's a number of you. This is fascinating and I'm going to rewatch it. We will make the recording available to everyone who registered, and it will be on the Maternal Health Learning and Innovation Center website. Now you're just getting
thanks. I'm just looking at the comments. Thank you, everyone.
Thank you so much, folks. Enjoy the rest of your day. Share this recording when you get it. We look forward to seeing you again.